Good evening, everyone. Welcome to our nephrology educational webinar series today. Today it will be our 131st series, and we have a very interesting topic on the highlights of Dr. Sundar's experiences with over 3,000 kidney transplants. So I'll be your host today. I'll be moderating this session. My name is Dr. Yuri Okech. I work with Africa Healthcare Network, and I can just do a brief introduction of Dr. Sundar. So Dr. Sundar completed his nephrology training from the world-renowned Christian Medical College in Bangalore. He went on to establish the nephrology and transplant program at MS Ramaya Medical Center in 1987 and founded the Karnataka Nephrology and Transplant Institute in 1991. In his illustrious career, spanning 4 decades, Dr. Sundar has experience of managing over 3,000 kidney transplants. He has special expertise in the management of complicated kidney transplants, palliative nephrology, and geriatric kidney transplants. Dr. Sundar is a recipient of the Dronacharya Award for the services in the field of nephrology. He is a former Adjunct Professor of Nephrology at Manipal Academy of Higher Education, a founding member of the Indian Society of Organ Transplant, Peritoneal Dialysis Society of India, and the Nephrology Association of Karnataka. So his areas of expertise are in complicated kidney transplants, palliative care nephrology, and geriatric transplants. So we're looking forward to a very enlightening discussion on his vast experience. So welcome, Dr. Sundar.
Thank you, Yuri. Thank you, Lloyd. Can you hear me clearly?
Before you start, Dr. Sundar, I think let me tell you, Dr. Sundar, my senior at the CMC Bangalore, phenomenal experiences with transplantation, unbelievable stories, and I think this is something that is really worthwhile. Spending time and looking through it again and again, the amount of experience that cannot be said in one hour for sure. So I think we'll only get a glimpse of what he's done. And I think he's the only person who's reached these numbers in India. So I think it's a privilege to listen to this session here today. Thank you very much, Dr. Sundar, for coming on. Extremely grateful for your time. And I know it's late as well, but thank you very much for coming on. And as well as his team, Dr. Tapoti, Dr. Venkatesh, and et al. All of them who are there as well. Thank you very much. Extremely grateful.
Thank you, Lloyd. You've been very kind to me, and I know you for so long. So what I'm going to do is I'm not going to talk much of theory as such. I'm actually going to talk more of my own journey in the last 40 years. And these are some of my disclosures. I'm on the advisory board of many pharma companies. And we should actually go back to the story of transplant, the world's first transplant, which was done in Boston. You see the picture here, world's first transplant done in 1954. And the man who did the first transplant, the surgeon Joe Murray, he got the Nobel Prize. I had the opportunity to meet him in 1992 in Singapore. I'm sure Lloyd also remembers, because the first time I met Dr. Lloyd was in Singapore, actually, in 1992, in a conference called Transplantation in Developing Countries. So we all stayed together in a small guest house, and we were cooking our own food. I'm sure Lloyd remembers that. So that is the time I met Joe Murray, who had done the transplant between 2 identical twins. So you can actually see the picture of the identical twins, Richard and Ronald Herrick. The donor, Ronald, was his twin brother. So they didn't use any immunosuppression because they were identical twins. But the story of the actual transplant in India goes back to my alma mater. The first transplant was done in CMC Bangalore, 1971. Actually, you can see the news item here. And these are the doyens, or my gurus, you can say, in the field of nephrology and transplant. Dr. P. Koshi, you can say. Actually, I would consider him as the father of nephrology in India. There's always a debate whether it's Dr. Chugh of Chandigarh or Dr. Koshi. Technically speaking, in my view, Dr. Koshi is the man who brought the first dialysis in India. 1962. The first dialysis in India was done in 1962. You can imagine 61 years ago, Dr. Koshi starting dialysis. The first patient actually was a Maharaja, or a king, a local king, and the nephrologist, Japanese origin nephrologist from Seattle came down to help Dr. Koshi to do the dialysis. So 1971 was the first successful transplant in CMC Bangalore. And here you can see my gurus. This is Dr. K.V. Johnny. You can say the man who started the nephrology department in CMC Bangalore. Dr. J.C.M. Shastri, my guru, he passed away. And Dr. Koshi, you can see Dr. Meshak Nyanamuthu Kribakar. In fact, I am a nephrologist because of this one man. He came to Bangalore and then he selected me to join nephrology in CMC Vellore. And this is Professor C.K. Jacob, now settled in Bangalore and helping us in the Bangalore nephrology scene. And this is actually the two pioneers who did the first transplant. Dr. Johnny here and Dr. Paul Mohan Rao with our foreign minister. We awarded them with the Lifetime Achievement Award in the conference we organized in Bangalore. That is a little bit of history of transplant in India. Now, my own journey goes back to, as Lloyd said, I'm a proud alma mater of, proud student of CMC Vellore. This was taken about 10 years ago, me and my wife. We always keep visiting Vellore. And this is an old photograph here. My wife, actually, you can see, standing in front of the Department of Nephrology. And this is my colleague, Dr. Deshpande, settled in Hyderabad. And one of the good things I did in CMC Vellore, apart from learning nephrology, was I created this fellow here. My eldest son, Raghav Sundar, he was created in CMC Vellore. And this is the guy who is now a senior consultant, a distinguished scientist. He's a PhD. He's the director of research at the NUS hospital in Singapore. So that way I have a lot of connection to CMC and owe a lot of my career and my family success to CMC Vellore. Now, this again, some picture of CMC. You can actually see Lloyd here. This is actually the retirement party of Dr. J.C.M. Shastri, 1996. Another senior colleague, Dr. C.M. Tyagarajan. This younger version of me, I had a lot of hair. My eldest son, Raghav here. And this was last few years ago. We had an alumni meet of CMC. You can see all the stalwarts of CMC. Dr. George Abraham, my senior. Then we have Santosh Koshi, the present professor. Then we have Chako Jacob, Anuradha, Dr. Hariharan. I'll talk about it later. Tamilarsi, all the seniors who have done a lot for CMC Vellore and carrying the flag of CMC Vellore in different parts of the world. Then this is again talking about CMC transplant. The first few transplants done in CMC Vellore. You can see here, they were only on two drugs, azathioprine and prednisolone. Actually, you can see they were on very high dose of steroids. When I joined Vellore 40 years ago, the steroid dose, oral dose, starting dose was 100 milligrams. And they would be on 100 milligram oral dose for many months. So you can actually see all of them having pushing out features because of the steroid effect. Only two drugs. You can actually see Dr. J.C.M. Shastri, Paul Mohan Rao, the man who did the first India's first transplant, settled in Australia. He has done a lot of work in Australia, operates even now at the age of 80 in Brunei, Malaysia. And this is Dr. K.V. Johnny. You can say the man who started the DM program, academic program in South India in nephrology from Vellore. If you look at my own state, Karnataka, if you look at the milestones, we also started more or less in 1962. The Mysore government got the first machine, but it was not functional. The urologist, actually, Dr. Jairam, who, his son, Nandakumar Jairam, was a teacher of Lloyd, as professor of surgery in St. John's. Then in Manipal, when I joined in 1971, the dialysis actually was started in Manipal because the Manipal institution was started by a man called Dr. T.M.A. Pai. And one of his son, Panduranga Pai, had kidney failure and they had to have dialysis. So they started dialysis in 1971. But actual nephrologist, to have a true nephrology situation, was done in Bangalore in 1979 in Bangalore Kidney Foundation by Dr. Talwalkar. This is Dr. Talwalkar and this is Dr. Mani, who's considered the doyen of nephrology in India. So we can actually see the Bangalore Kidney Foundation in the early 1970s and Dr. Talwalkar taking care of the Kidney Foundation. Now, I give you a timeline of the dialysis in Karnataka, 1980 St. John's. And many of you may not know, it was Dr. Brian Pereira and Lloyd Vincent were involved in, especially Brian, in 1989. The CRRT concept, I still remember Brian as a young nephrologist. He had come down from Chandigarh. I know that Brian is part of your Africa network and his son is running the program here. Brian actually had the CRRT session in a small hotel, I remember, in Bangalore, and we all, only about a handful of us nephrologists attended the program. Then after that, Brian moved to US and has made a big name. Then I joined in 1985 in St. John's Medical College. Many people don't know that. I joined under the urology to start a nephrology department. So nephrology was under urology. Then we have a lot of others who joined. Brian is one, Dominic who joined from St. John's. Then going on, I would say the history of nephrology, when I joined in 1985, we were only a handful. Now, Bangalore city itself, we have got 150 to 200 nephrologists. The community has grown big. But when you talk of ESRD, I always start with this one man called Kamal Shah. You see the picture here. Kamal Shah was a young man about 27, 28 years ago. He was actually going for US and he got the US visa and then he was going for a job there. he had a vaccination, and then in a few days after the vaccination, he was very sick and he had kidney failure. And it turned out to be that nobody knew why he had kidney failure, but he needed dialysis. Then he met my teacher in Hyderabad, Professor J.C.M. Shastri. They diagnosed that he's got probably hemolytic uremic syndrome, atypical hemolytic uremic syndrome. And then they did a transplant. And Dr. Shastri very clearly explained to Kamal Shah that you are having hemolytic uremic syndrome, and the drug we use in transplant is something called CNI, calcineurin inhibitor. And those days it was cyclosporin. And there is a very likely chance that this disease may recur after transplantation. So Kamal Shah said, I need the transplant, I'll go ahead with the risk. And he had the transplant, and his bad luck. Within a few days, he had hemolytic uremic syndrome and lost the graft. So Kamal had to go back on dialysis. After a few months of dialysis, he went on peritoneal dialysis. He was doing very well on peritoneal dialysis. In fact, in those days, peritoneal dialysis was not common, even though it's not very common in India. In my own practice, even in Bangalore, not even 5% of ESRD are on peritoneal dialysis. But Kamal was doing very well on home dialysis, peritoneal dialysis. Then in December, about 25 years ago, he was in a place called Chennai, which is formerly called Madras. He was holidaying in the beach, and a tsunami hit the whole resort town, and he was nearly drowned. And after the tsunami, he developed a peritonitis, probably fungal peritonitis, and they had to remove his PD catheter, and then he went on regular hemodialysis. But Kamal is a guy who was very innovative, and he founded this largest chain of dialysis center in India called Nephro Plus. And you can see Kamal here on dialysis. He's dialysis at home every day. And we had a meeting about 10 years ago with Kamal, and you can actually see Brian Pereira and me here with Kamal Shah and Prakash Keshavaya. Those of you in the field of dialysis will know, Prakash is the man who actually got the concept of pure water to treat water. Because many of us in those days, I remember when we were in CMC Bangalore, water was not very important. We were just using any water. But the concept is you can't clean dirty linen with dirty water. You need clean water. So what is dialysis? You're cleaning water. So the concept of clean water was introduced by Prakash Keshavaya in the US. Then he brought it on to India. He's still working at the Himalayan Institute of Medical Science in Dehradun as an advisor. And people do contact him for opinion on water treatment and dialysis. That is Prakash Keshavaya. And I always give the story of Kamal Shah because he is one man who has gone through the entire spectrum of all treatment for ESRD, starting from hemodialysis, transplant, PD, back on hemodialysis, and doing everyday dialysis. He is now waiting for a transplant, actually. He wants to go for a second transplant, but he will only do it when India gets its own eculizumab so that he can treat it. Because eculizumab is the one we treat using for atypical HUS, it's very expensive. It's equivalent of, they say a year's course will cost about 2 crores. Lloyd should be able to convert it in dollars. I think how many millions, I don't know. At least I know that 1 million is 8 crores, maybe $250,000 every year would be the cost of eculizumab. So Kamal is waiting for the Indian equivalent of eculizumab to come in to go for a second transplant. Now, this is again some the milestones in our nephrology. We organized the first Southern Chapter meeting in 1986. You can actually see me here, a lot of hair and very young. This is about 37 years ago. This is Professor K.V. Rao from US and Professor Amaresan from Chennai, who is the one who started the Southern Chapter meeting. Then if you look at the history of a little bit of in Bangalore, we started the first PD meeting or the PD Society in 1997. Hemodialysis Society was started by Dr. Balal and Kishore Babu. Then we did have a little bit of pediatric nephrology by Dr. Fadike. Now, transplant in Karnataka, the first transplant was done in 1983 at Lakeside Hospital 40 years ago. That's where I used to work. Then the Ramaya Medical College in 1987, where I formed my team. Then we had a few other centers doing many transplants. But the story of transplant is also a story of a lot of legal issues, ethical, moral. I'll come to that. Then we did organize in 1997, 27 years ago, the transplant sports meet. Actually, you can see Lloyd here, looking as Lloyd still looks handsome and young. And this is the winners of the transplant sports meet. These are three actually transplant recipients who won the medal. And this is my son, Gaurav, who is now a senior consultant interventional radiologist in Scotland. So you can see him holding the plaque for giving the awards for the sports ceremony. Now, if you could go into the history of dialysis, this is how it was in 1970. This is actually in Manipal. The photo is taken in KMC Manipal. This is Dr. TMI's son undergoing dialysis. And in 1950, it was like this. Now we have modern machines like this. And this is actually in 1990 in my own center. You can see me here. 30 years ago, I was young and a lot of hair. 30, 40 years in the field of transplant. You become bald and old. And that's the way. That's part of, I would say, professional hazard of transplantation. How are we doing vascular access? That is very important. A lot of people have not heard of this called AV shunt. This is the commonest way we were doing vascular access. We never had, in my training in Bangalore, I didn't have dialysis catheters. We didn't have central vein catheters. And even emergency dialysis, we had to do something called AV shunt. Here you actually see in the leg vein, the artery and vein connected by a silicon tube with a, it is a silicon rubber tube. And that's how every time you want to do dialysis, you have to disconnect here, connect the artery and vein. And this picture came in the advanced chronic disease. And my good friend, Ken Ebrio, we can say is one of the doyens in the field of intervention nephrology. So Ken saw this picture and put it in the Journal of Nephrology. It was very nice to acknowledge our work from Bangalore. Incidentally, Ken's parents were in Bangalore, so I know him well for the last 30 years. Now he's retired, spending time as a grandfather with his grandkids. So that is the story of intervention nephrology and the Bangalore connection and the AV shunt. But we started using dialysis catheters like femoral catheters, central vein catheters in the 1990s. But the earlier form was the AV shunt. Later on, they would go into AV fistula. Now, when you look at the shortage of doctors, I think that is one of the problems which we have been having. We are lucky in Bangalore that we have a lot of nephrologists, but the whole of India, if you see, we are still short of transplant surgeons in nephrology. And I'm sure this is the problem which we are going to face in Africa, because we are going to get poached. A lot of good doctors will get poached by the Western world. Ajay Singh from Harvard made a very important comment that he said there are more nephrologists of Indian origin in USA than India. So this is very surprising. This quote was made about 10 years ago when I met Ajay in Harvard. We had about 1,500 nephrologists in the Indian Society at that time. And the American Society of Nephrology had more than 1,500 nephrologists of Indian origin. So that is the magnitude of the problem of shortage of staff which we used to have. Now, again, looking at the magnitude of the problem of ESRD, this again, we have the ESRD CKD registry, but still, I won't say that it's perfect. So I coined this term called guess estimate or guesstimate. So guesstimate of ESRD in India, roughly 250 new cases per million per population. That means we will have 250,000 new cases every year. And the number of nephrologists presently, I understand, we are about 2,500. And there are more than 1,000 to 1,500 nephrologists of Indian origin in the US. We do about 7,500 to 10,000 transplants a year. Actually, we need to do 200,000 transplants a year if you go even by conservative American standards. Now, the problem in India is most of the problem, 50% of my transplant or dialysis population is due to diabetes. And if you can see how China and India, we are competing each other. As of now, we have overtaken China in population. We are the largest populated country in the world. So we are also the largest diabetic capital of the world. And if you look at the incidence, this is a 25-year-old slide, nearly 50% of my ESRD are all diabetics. This is very, and my own analysis, I analyze about 3,000 transplant, and if you see, nearly 42% of my transplant patients are diabetic. And another 43%, they would come to me for transplant. Of late, in the last 5-10 years, we are getting the native kidney diagnosis because of the biopsies have become common. But biopsy was not common. Most of my patients would come for transplant. They would come with small kidneys. So I coined the term GOK, God only knows, because they got small kidneys. But I think they would be having chronic glomerulonephritis or chronic interstitial nephritis. Then we did have APKD. Then miscellaneous, I put, if you see, IgA, because the number of biopsies knowing native kidney disease was very less. So, but to cut the story short, 50% of my transplant recipients or dialysis patients are due to diabetic ESRD. That's why this man, Eli Friedman, those of you who heard his talk, he used to come regularly to India. He was the man actually who was treating one of the popular chief ministers of Tamil Nadu, a man called M.G. Ramachandran, way back in the 80s. And he used to visit India often. And he coined the term that ESRD is an epidemic and diabetic ESRD is a pandemic, more so in India and in the Asian population. So if you look at kidney failure, Most of the time in the 13th century, they said there is no treatment at all. But by and large, we know what are the treatments available. The treatment available for ESRD is hemodialysis. Death is another option. People think that death is not an option. Actually, it's now part of the palliative care. We accept that death also could be a form of treatment for ESRD. Then transplant, then peritoneal dialysis. As I told you in my own experience, the PD is not even 5% of my ESRD treatment. Majority are on hemodialysis and transplantation. Death is very important in our country. People don't even know they have kidney failure. People have kidney failure, and invariably, all kidney failures will have some heart problem, and they may die of hyperkalemia, and they are always blamed that person had a heart attack and died. So they may not even know they got kidney failure. That in a way is good. Ignorance is bliss. It is folly to be wise. So if you don't know about kidney failure, and if you're taking a lot of potassium and dying, it may solve your problem, but that is by the way. So that is one. So the people keep asking me, I'm in the field of transplant. I claim to be a transplant nephrologist. So I always say transplant is the best option for ESRD. Is it true? Is there scientific evidence to say transplant is better than dialysis? I always say this statement: the most important risk factor for ESRD is not getting a renal transplant. Again, this is not my own theory. So I put this slide. Once you have CKD, in my olden days, we used to call it chronic renal failure, and it was simple. I keep talking. My days, things were simple because we had very few terminologies. CKD was called chronic renal failure, and we had mild, moderate, and severe. That's all. Now we have CKD 1, 2, 3, 4, 5, so many stages, lab oriented. But nevertheless, when you say CKD, invariably it will go into ESRD. And once you have ESRD, this is the best option, I would say. That's why this arrow is fatter than the other arrows. So transplant would be the best option for ESRD, in my opinion. Now, I would coin this term: magical cure of kidney failure is kidney transplant. Because if you look at dialysis, a lot of people come and ask me, sir, if I do dialysis, will the kidney improve in chronic renal failure? Dialysis is a double miracle. It keeps the patient alive and the disease alive. The renal failure, kidney is still failed, and the patient is alive. No other treatment, you have this double miracle where the patient and the disease are alive. Whereas with the transplantation, you have a magical cure. That's why if you look at Peter Morris, Sir Peter Morris, he said that the best form of treatment for diabetic ESRD is transplantation. Commonly, I don't know about Africa, but at least in my country, the moment I tell somebody who's got diabetic kidney failure, I tell them you have to go for dialysis and then transplant. The next question they ask, sir, he's got high sugar. Sir, he's got high blood pressure. They think high sugar, high blood pressure is a contraindication for transplantation. It's not so. I have to tell them their problem of high sugar, high blood pressure is no contraindication for transplant. It is better that they go for a transplant. So this is a slide which I always show, that how transplant has got the best chance, especially the quality of life, nothing to beat a successful transplantation. But more than that, if you look at the survival figure of diabetic ESRD, it's a very old slide. But still, 2001, 23 years ago, but still it holds good even now. Look at this picture. If you have a transplant live donor, look at the survival figure over 10 years, then cadaver transplant, and somebody on dialysis. If you take 100 people here, at the end of 10 years, all the people on dialysis are dead. With a live donor transplant, 60% to 70% are doing well. So even if you look at the mortality rate, getting on to transplant is the best option. In fact, my colleague Hariharan I will talk about him, tells me that even getting on the waiting list for transplant, chance of survival are better than just being on dialysis. Now, this again tells you the number of years left with a normal person with a transplant on dialysis. If you look at somebody who's got at the age of 40 on dialysis, you have got just 10 years life compared to somebody who's no kidney failure. So no question at all that transplant is the option for ESRD. There's no argument on that. There is science behind it, and our own experience shows that. Now, once you do transplant, the next question comes, as I told you, if you are doing a transplant with an identical twin, like what was done by in Boston in 1954, you may not need immunosuppression. But immunosuppression in my days, I joined CMC Vellore in what I call the BC era. I'll come to that. So this is the immunosuppression we use. This is the timeline of various immunosuppression. I won't go into detail because all of you are nephrologists, and I will just go into my own experience of the two era. The BC era is not the before Christ era, it is before cyclosporin era, and AC era is after cyclosporin era. I'm sure most of you are from the AC era. I'm fortunate from the BC era because I joined CMC Vellore 40 years ago, and those days we didn't have cyclosporin. We just had azathioprine and prednisolone, no cyclosporin. And if you look at the evolution of immunosuppression, if you look at the graft survival, one drug which actually made a lot of difference in the success of transplant is cyclosporin. In my opinion, cyclosporin or the CNI, calcineurin inhibitor, now we shifted to tacrolimus. That is the one drug which has made a dramatic change in the success of transplant. I don't think we have still got any new drug in the last 30 years to change the results of the 1 year survival at least. Even the long term, in my view, one drug which has made the difference, the magic bullet I could call is cyclosporin. Now, this is again the transplant immunosuppression, starting from the first transplant, what is happening now. I'll come to that later on. Now, whenever we do transplant, in our days, in 1995, we had the first monoclonal antibody in transplant. Before 1995, I started my program in the 80s. We never had any induction. We could just go out transplant. Then we started using monoclonal antibody called OKT3. We used to use normal doses, 10 doses. I was using only 5 doses. Very expensive. The first dose could be fatal. They have called the first dose effect, which is something like what COVID would do. You know, the immune crisis. You know, because of that overreaction, people would die. Then we started using daclizumab from Roche company, which is sold as Zenapax. That stopped in 2009. We were one of the first to use basiliximab or Similac. And I would say, in my experience, it's more a costly placebo. And I am not actually for Similac in my day-to-day practice now. This is the thing which is going on, debate goes on. My common way of using induction is a rabbit thymo. I use both ATG and Grapholon. Rituximab opens a lot of hope now. Eculizumab for atypical HUS is there, but I don't know. The question now is, if you're doing a close live donor-related transplant using tacrolimus, mycophenolate, prednisolone, do you need induction? Because induction is costly. My friend Hariharan, again, I'll come to that later on. Hariharan told me that instead of using costly induction, it is better to keep the money for long-term immunosuppression. Because one of the reasons grafts fail in our country is patients can't afford to keep buying the drugs. These immunosuppressive drugs are costly. They stop drugs. I'll come to that. So he says using the induction money for long-term maintenance therapy is sensible. Now, this is our protocol over the last 3 decades. Early 80s, we were using azathioprine, prednisolone. Then we were using Neoral, that is cyclosporin, Neoral, prednisolone. Then we shifted to mycophenolate, prednisolone. Then we shifted to three drugs. This is the current gold standard, I would say, TAC, mycoprednisolone. In my opinion, I have quite a few patients on TAC and AZA because it's a cheap alternate. It's worth using it. I don't think AZA is anyway inferior to mycophenolate in live-related donor transplant. That's my view. I'll come to that later. I've used everolimus and sirolimus. In fact, I was part of the ascertained trial of everolimus and made by Novartis. Some are not a popular drug, but there are certain indications. I will do that. I will also talk a little bit on my own large experience of single-dose tacrolimus called Lipogram. Now, whenever I talk on transplant, I told you of BC era and AC era. That is before cyclosporin and after cyclosporin. Originally, it was called Sandimmune because it's made by Sandoz company. And I always show the picture of this man, Dr. C.M. Tyagarajan, again, an old student of CMC Vellore. Probably the man who's got, Lloyd said that I've got maximum experience. I got 3,000. Lloyd, for your experience, Tyagarajan has got 5,000 transplant experience. And see, many centers will have large experience. You look at Apollo Hospital, they may have 6,000. Vellore have 10,000. But an individual nephrologist having 5,000 transplant is rare. Because what happens when you work in a big institution, it is not an individual nephrologist. Each nephrologist will be having their own cases. But we are very few from the CMC Vellore. One is my senior, Dr. Tyagarajan. He actually taught me how to use cyclosporin. There's an interesting story about use of cyclosporin by Dr. Tyagarajan. Dr. Tyagarajan was treating this man, M.G. Ramachandran, a famous movie star for our African friends, I must tell you. He was the rock star of South India. Then he became the chief minister, politician, and people would give lives. When he had kidney failure, millions of people offered kidney, and some of them even committed sort of self-immolation. They were upset that this man had kidney failure, they burned themselves. So that is the popularity of this one man called M.G. Ramachandran. So when M.G. Ramachandran had kidney failure, he was flown to the United States, to Downstate Medical Center, to Dr. Eli Friedman, and the surgeon who did the transplant, this Pakistani origin guy called Khalid Bhatt. But that is the time Tyagarajan learned how to use cyclosporin from his dear friend called Manikam Sudandran. Manikam Sudandran, again a Tamil Nadu origin guy, settled in US, a big man. He's got the Medevar Award and is a big name in transplantation. So Manikam actually told Tyagarajan, start using cyclosporin in India. You can start doing unrelated transplants, meaning you can do HLA unmatched, unrelated transplants. So Tyagarajan came back to India, and then the whole started the process of unrelated transplant. Buying, selling kidney was common. I will come to that, even I was involved. But when you look at that era, cyclosporin made the difference. People without cyclosporin, that was not possible. That's why I put the whole picture. These are twins in Boston, twin girls. These twins actually were the first twins recipient to have children, donor to have children in the world. They could prove with a transplant, as a kidney donor, you could have children. With a as a transplant recipient, you could have children. Now, this again is my one of my favorite actors, Selena Gomez. She had an unrelated transplant from her friend. And why was that possible? Because of tacrolimus or CNI. Now, this drug, as I told you, cyclosporin, CNI, tacrolimus, has made the success of transplant enormous. Now, any drug has got side effect. I keep saying all drugs which have got effect will have side effect. Any drug which has no effect will not have side effect. In India, we have a system called homeopathy. People come and tell me homeopathy has no side effect. Because homeopathy has no effect. If you don't have an effect, there's no side effect. Now, what are the side effects of drugs? All of you know that. And this I put in my own favorite movie, The Good, Bad, and Ugly. Good, Bad, and Ugly of transplant. One of the problems, the side effect, is the treatment. Either it is the CNA, cyclosporin treatment, or tacrolimus, or the side effect of steroids. Now, let me come into this important aspect of cyclosporin. One of the problems with cyclosporin was hirsutism. You see this, one of my patients, she was on cyclosporin. The kidney was donated by her brother. After this, she became like this. And the brother came and told me, sir, I think you've done a mistake. You've taken a man's kidney and put in a female. That's why she has become like that. He didn't know it is because of cyclosporin. Moment you change from cyclosporin to tacrolimus, you can be like this, like Selena Gomez, not my patient, or another patient of mine. She has had 2 transplants with me on tacrolimus. One other important thing with cyclosporin is gingival hypertrophy. Every other patient would have this problem, and my dental department would do removal of the gums or gingivectomy. Moment you switch over to tacrolimus, this side effect would go away. So this is the problem I had with cyclosporin. So tacrolimus is cosmetically good, but there are other problems. I'll come to that later on. Now, this is one problem which made me switch from cyclosporin to tacrolimus. Now, one other problem of cyclosporin, which very rarely we face, is TMA. I told you about the case of Kamal Shah, who had TMA, hemolytic uremic syndrome. Very rarely this could be a problem, and we have to be aware that when you are on CNA, especially cyclosporin, this could cause a graft failure. Now, this I must tell you of a story of a young lady from Nigeria. Now, this lady had the first transplant with me, and she was on cyclosporin, and within few days, she lost the graft because of TMA due to cyclosporin. That's what I think. And that time, that was the theory that if you use sirolimus, you may get away from this problem. Now it's not accepted by all, but I did use sirolimus for her. She did very well on sirolimus. Many years she did well, but it so happened her husband, a lawyer, said that she should get pregnant. And one of the things with sirolimus is it is not acceptable. If somebody on transplant wants to get pregnant, sirolimus was not the drug. You'll have to stop mycophenolate. The ideal drug was tacrolimus, cyclosporin, azathioprine, prednisolone. So I told her, don't take the risk because you lost the graft. Don't go back to cyclosporin or tacrolimus. But she didn't listen to me. She shifted to, on her own in Nigeria, to cyclosporin. And within few months, I heard she was dead. So this is one thing which I feel bad. So maybe if she had belatacept or something else, you could have saved her. I don't know. This is an old story, but it always haunts me. This young lady, I couldn't help in any way. Now, when you look at transplant, is it always successful? No. No transplant is successful. It's like marriage. Transplant is like marriage. It's a blessing for many. Incidentally, I'm married for 42 years now. It's been a blessing. It can be a curse for some, but a risk for all. Same with transplant. If you have a successful transplant, great. But you have a transplant with rejection, infection, it's a curse. But you've got to take the risk of transplant. Only then you'll know whether it's a blessing or not. Now, this is another important story I had in an African patient who had Kaposi sarcoma after transplant. One drug, I told you, everolimus, this is a wonder drug. I stopped cyclosporin, put him on everolimus, and the Kaposi sarcoma vanished. But now, the problem I'm having is he's got proteinuria, but that is manageable with ACE inhibitor ARBs. So this drug, everolimus, is amazing. Sirolimus is an amazing drug in situation like Kaposi sarcoma, where the sarcoma could disappear. Specific indication for using everolimus or sirolimus. Then I come to my own experience of using single-day tacrolimus, commonly sold as Advograph, but now we have an Indian brand called Adventa. So I started using this for many reasons. Some of the reasons are, in fact, I presented this study in Korea and Singapore, and we have quite a large number of patients on single-dose drug. And one of the reasons is, if you look at the usual dose of tacrolimus, it is twice, morning and evening. There is a theory that there is less absorption in the night when you use the evening dose. And my reason, this is an old slide, this is about 15-year-old slide, I got more patients on that. Some of the reasons why I shifted to Advograph or single-dose tacrolimus was rise in creatinine for no reason. You do biopsy, we don't know what's happening. Some of them high tacrolimus level. Whatever you do, even on 0.5 milligram BD of tacrolimus, levels are high. Some of them low levels. You give them high dose, still the levels are low. Some have delayed graft function for no reason, and some by choice. Some of the patients said, I want this drug. So if you look at the my own experience, the pre-conversion TAC level, the highest was 30, lowest was 1.3, average was 11. Once I converted, the average was 6, more or less the range which I wanted. My range is 5 to 7. So I achieved that by using Advograph or single-dose tacrolimus. Now, the dose of Advograph varied. The highest dose I used was 10. The lowest was 0.5. Average is 3. Now, if you look at the number of patients, average creatinine, if you look at the conversion average, was doing well. So my experience of Advograph has been a boon. It's specifically useful in conditions where patients after transplant have tuberculosis. In tuberculosis, the common use is rifampicin. I normally don't use rifampicin in transplant principally because rifampicin reduces the immunosuppressive dose. The steroids, cyclosporin, all of them, the levels come down and it's not easy to manage. But with Advograph, it is easy to manage. This is a professor of medicine who had miliary tuberculosis. In such a situation, a resistant tuberculosis, we have got to use rifampicin. Otherwise, I just use INH, ethambutol, pyrazinamide, ufloxacin, prednisolone. This is my common regime in the post-transplant tuberculosis. But a professor of medicine like this who had miliary tuberculosis, I put him on Advograph, I put him on rifampicin, and he's doing well. And he's now off all of this except the immunosuppression. So this is one of the reasons I do use single-dose tacrolimus. And what is the level of tacrolimus we should have? What is the trough level? This is again a Taiwanese study, and he suggested the ideal trough level, even maintenance, should be above 5. So I always keep it in the range of 5 to 6. But in a jovial form, during the dinner, I asked Dr. Wu, how did you get this figure of 5? So he said, we have got 5 fingers, so it is 5. I think jokingly said that. But nevertheless, my protocol of maintenance of TAC level is around 5. Now, this is some of the things. This is again my good friend Vijay K, who came and visited our stall. And he has also got a lot of experience in using Advograph or long-acting tacrolimus. One other thing which I formed is, this is a neurosurgeon colleague of mine. He's a good golfer and his brother donated. This guy told me that he operates from morning to evening and in Bangalore traffic that he can take all the drugs only in the morning. So what I did was I formed a new regime called Advograph, azathioprine, prednisolone, ARP regime. So all the drugs he takes in the morning, he's actually on 2 milligram Advograph in the morning, 50 mg of azathioprine and 5 mg of prednisolone. That's all, nothing else. All 3 he takes in the morning, spends the whole day operating, playing golf. So I have quite a few patients who are on these sort of drugs, 3 drugs. I am a proponent of using azathioprine. I use quite a few patients on azathioprine. Some of the patients on mycophenolate, for many years later, they have some diarrhea. The diarrhea, we can't find out whether it's due to infection because India, diarrhea is common because we eat outside, our water is not very clean. I'm sure the same in all developing countries. So if those things, treatment of infection doesn't work, if the mycophenolate is still there, I stop mycophenolate, put them on azathioprine, and they've done well, the diarrhea disappears. Now, one of the problems in Africa and other countries, like including mine, is compliance. And when you look at compliance, there are three distinct features of non-compliance. One is accidental non-compliance, invulnerable compliance, decisive non-compliance. This is a very interesting story. My colleague Anaga and Topati will remember. This man came to me 3 days ago from Yemen. I transplanted him 4 years ago, and he came to me. He had not seen any nephrologist in Yemen or anywhere in the world. He has not done any test, no creatinine, nothing. He just comes for follow-up, and I asked him what are the medicines he is on. So he shows me 3 boxes. You can see 3 boxes, and I'm inspecting the 3 boxes. One box contains tacrolimus, mycophenolate. Second box contains antidiabetics and antihypertensives. Third box contains some B complex and other things. And I remember putting him on steroids because I am a fellow. I don't believe in steroid-free regime, to be honest. In a country like India, I feel steroid-free requires a lot of monitoring. It may have specific indications like children where you can monitor. So my colleague, again, Dr. Hariharan told me, as far as possible, please put them on a small dose of steroids. So when you look at it, he's not on steroids. He stopped his prednisolone on his own. Now, when I looked at it, I was shocked. I thought this fellow's creatinine would have gone up. I'm sure he needs dialysis. So I got the creatinine done, and immediately my colleague within an hour managed to get the creatinine. Yes, creatinine, it is 1.2. Now, the question now is, he's off steroid for 4 years. Should we put him back on steroids? Again, I told you, he's going back to Yemen. I don't know what's going to happen. 5 milligrams small dose of steroid will not harm anybody. So I put him back on 5 milligrams steroids. So he's on tacrolimus, mycophenolate, 5 milligrams steroid, and the other drugs now. Only thing I have to educate. So the most important thing is we have to tell the patients to educate. We have to spend a lot of time. What are the drugs? Because most of the time they'll tell you I'm taking a red pill, blue pill, green pill. So we have to educate in transplantation for compliance. Now, one other thing is if you miss the drugs, if you miss the immunosuppression, even 1 or 2 doses, you can have antibody-mediated rejection. So how do you treat antibody-mediated rejection? There is no specific treatment. If you look at the guideline, there is no treatment. All this we have tried, starting from thymoglobulin, rituximab, bortezomib, plasmapheresis, eculizumab. I have not tried. IV immunoglobulin, everything has been tried. No specific treatment advised for antibody-mediated rejection. But by and large, I know the protocol is plasmapheresis and rituximab and IVIG. That's why I always show this picture. This is actually an old story of an elephant with 4 blind Indian men. They look at the elephant. One of them looks at the trunk and says it's a snake. Other fellow is looking at the tail and thinks it's a furry mouse. Third fellow is looking at the ear and says it's a sheath of leather. The fourth fellow is looking at the leg of the elephant and says it's a tree trunk. So we nephrologists, according to me, we are like this blind Indian men treating antibody-mediated rejection. We don't know what to use. Rituximab, bortezomib, thymoglobulin, plasmapheresis, we don't know. So I myself don't know what is the best treatment for antibody-mediated rejection. I can pray that they don't get this rejection. Now, I'll give you a few success stories of transplant. We have patients from all these countries, from Bangladesh and a lot of African countries. Now, my youngest transplant was a Malaysian Chinese girl. She was 5 years old when she had the transplant. This is in 1993, 30 years ago. Actually, I lost her last year. She's just 35 and we lost her. This is a Nigerian chief who had a transplant. He was 75 when he had a transplant. This is my colleague, Dr. Ajit Wilgol, who has been with me for the last 37 years working as my transplant surgeon. Now, this is again some of our success stories who had transplant in my OPD, where some of them had just a month ago, some of them are finished 35 years ago. This fellow has finished 35 years ago, only on azathioprine and prednisolone. No cyclosporin also, doing well. Now, my friend Hariharan, I must tell you a few words. Hariharan was my classmate in CMC Bangalore. He was smart, bright guy. That's why he went to USA. I was not so smart. I stayed back in India. And he is the one who said the best marker for transplant is serum creatinine. You have a lot of markers. So he coined the term for transplant. Creatinine is still the best marker. That is Hariharan here. It's me and my friend Rajiv Gandhi, also from CMC. And he said, if you look at the serum creatinine, the first year of serum creatinine, that will tell you how long the kidney will work. And this picture again from Brazil, from a Brazilian nephrologist, where they tell you that creatinine is very important marker. This is in a subway and metro, a model is advertising saying creatinine is the best marker of kidney function. So in transplant, the best marker, whatever you may have, you've got a lot of markers. Even now, a country like India and Africa, I think we still go by creatinine, and I swear by creatinine. Now, this again, some of our VIP patients, this is the vice president of Fiji. He has had 2 transplants. So Dr. Ajit and me visited him in his presidential bungalow, doing well after 2 successful transplants. Then we have the first African patient who had transplant with me is a commissioner of police from Nigeria, 1999. He actually came to me referred by a professor of medicine and nephrology, Professor Maba DJ from Lagos University Teaching Hospital. He actually had seen my comment. We had a group those days. We didn't have social media. We had something called Nephron, started by Kip Solis from Canada. Lloyd knows him. We had an email group of 3,000 nephrologists all over the world. Every day we'll put our problem in the email. That message will go to 3,000 nephrologists and somebody will comment. So I have some problem, I put that. So like that, I had made some comments. The Nigerian professor was impressed and he said, I have a commissioner of police, but he has no money. He's got only $10,000. And most Nigerians who can afford could go to UK or United States for transplant. But this police officer is an honest police officer, so he has no money. If he's a corrupt police officer, he will have a lot of money. Being an honest police officer, I'm sending you to India with $10,000. He did very well. So he was our brand ambassador. After that, we have done for a lot of Nigerians. This is again a young girl, 13-year-old, 14-year-old girl who had transplant. The mother was the donor. And so that way, success of transplant, the question comes, can transplant recipients get married? Can they have children? Now, this is again an interesting story. 2 of my recipients got married 2 years ago. This is again 2 recipients got married. So you can get married and you can have children. Now, the question is, what do you do after transplant? This is the question people keep asking. Is pregnancy safe in transplantation? In my opinion, pregnancy is not safe even in non-transplant. Pregnancy is not physiological according to me. Even every month, we have one case in a normal person, so-called normal person, pregnancy-induced HUS, HELP syndrome, kidney failure, cortical necrosis, we have that. So pregnancy is not normal, even in normal people according to me. But then we have some protocol in transplant. What do we do? In my opinion, they should have normal, stable creatinine at least for 2 years. No rejection episode, well-controlled blood pressure, proteinuria of less than 500 milligram. And we invariably should stop ACE inhibitors, ARB, mycophenolate 6 weeks prior to conception. This is very important. So when they have transplant, we have to counsel them, especially young women. Now, very interesting scenario I'm seeing, which I was not seeing before. We are seeing young women coming for transplant, donating their ovum and freezing the ovum. They're saying, okay, I will have transplant, but my ovum will be frozen. I'll get married later on, and then that ovum can be used. This is being seen not only in transplant recipient. I have some of my friends' children who are young ladies who want a career in software, they want to go abroad. They are doing that now. They are freezing the ovum and then going on with their career. So this is now becoming common to store the ovum before transplantation to have pregnancy. But these 2 you see here, they have gone through pregnancy after transplant and produced children who are healthy. Now, these are some of the successful stories of transplant. This is again the patient of mine, Rajini, settled in Australia. Twin children, they came recently here. These 2 girls consider me as their grandfather. Anjana and Sanjana, twin girls of Ranjini, who had transplanted with me 27 years ago. That's her husband, settled in Australia. So these are some of the successful stories. Now, what about men? Men have no problem. This is an Islamic scholar from Nigeria. He had transplant. He has got 8 wives. Honestly, I'm not bluffing. 8 wives. And these are the 3 children after transplantation. And whenever he comes, his first wife is always there. She will always be with him. And that is the power of transplantation. For men, invariably, the producing children is not a problem. The transplant immunosuppression doesn't affect the sperm the way we think so. But women have issues. That is the success of the transplantation. Whether after transplant, what about jobs? This is an IG of police in Bangladesh. She is the first Bangladesh police officer who had transplant with me. This is a homemaker who had transplant. These are some of the success stories. Then again, one more patient of mine, she had transplant 27 years ago. Her native kidney damage was because of what is called Ayurvedic medicines. She took native medicines, lost the kidney, and then went for transplant. After transplant, she developed 3 cancers: renal cell carcinoma, then one sarcoma, then a hemangioma of the liver. She's doing well. But these are success stories. Actually, I would say these are patients who inspire us to do more work. So I'm grateful to such patients. I'm grateful to God that we have such patients. Now, again, if you look at the success of transplant, this is Alonso Mourning, who's a basketball star, who after transplant got this award. And this is actually him and me taking his autograph in Boston 15 years ago. that is Alonso Mourning after transplant. So transplant recipients can become sports person like Alonso Mourning. This is our own patient who won a lot of medals in the transplant games. And then some of the lessons from I learned from Africa. Actually, I would say I love Africa. In my next life, I wish I'll be born in Africa, to be honest. In fact, I feel jealous of Lloyd because he spent so much time in Africa. So this is one of the early visits to Africa, and this is a Maasai girl, and she told me I could get married to her, but the only condition, she said that if you have to marry a Maasai girl, I must have 4 cows. And she told me that her father actually wants 40 cows, so I couldn't afford even 4 cows, so I didn't marry her. That's the difference. Now, recently I was in Zambia to help the Zambian government to set up transplant. This is actually my colleague, Dr. Ajit, and we had some inauguration, and Dr. Agre, or the nephrologist Mutumba. I'm sure Lloyd knows them. We did a few transplants for them, helped them out. A lot of infrastructure problem we had, starting from lights to water to the pumps, a lot of things, but we managed, so it's possible to do transplant. Now, my own experience, this is over 2013, we had done about 250 transplants, and what are the problems I have? Just a few minutes. These are the problems I noticed. History of malaria, schistosomiasis, vascular access problem, because invariably, at least in those days, they would come with a femoral catheter. The femoral catheter will be there for many months. They wouldn't remove because still the concept of jugular and subclavian was not there. So they would have endocarditis. Then they would not take drugs. They would miss out. Then some of the patients with Jehovah's Witness, we had to bloodless transplant. So these are some of the problems I noticed. It is not specific only for Africa, but I would say that this is the problem I noticed in my transplants from Africa. And I must give credit to Dr. Bang Boy from Nigeria. He has done a lot of work on this. Interestingly, Bang Boy and his colleague, Dr. Shonibai, spent 1 month with me for learning transplant in developing countries. Both are highly qualified nephrologists and surgeons from United Kingdom. So this is my experience. When you're trained in a country like UK or US, when you come to a developing country, you want perfection. It's not possible. If you want perfect ICU, perfect HLA lab, perfect things, you can't do that. So when I started transplant, it was actually in a small hospital with not even 2 operation theaters, no oxygen cylinder, still we did the transplant. I would say perfection is enemy of good. So Dr. Shonibar and Bang Boy came to India and they were surprised with less infrastructure, we were doing so many transplants. So that stimulated them, inspired them to go back to Nigeria and start their transplant program. So that is one. Now, this is again my own Nigerian patients who had transplant, successful transplants. And this is a group of 8 brothers who Alport syndrome. 4 of them had transplant with me. Very unfortunate, but one advantage was that they had many siblings. And that is, if you have a big family, getting donor is not difficult. This is a story which I keep showing. This is a pastor, Reverend Morgan, who came like this with advanced ascites and kidney failure. And then he had transplant. He became like this. He wrote many books. Interestingly, he had 2 transplants. The first was given by his wife. Then that rejected because he missed his drugs. He himself told me the drugs were not available in Nigeria. So he stopped his immunosuppression for a few weeks, lost the graft. Then he had a second transplant. Before the second transplant, as I told you, he had a catheter for dialysis for a long time. He developed endocarditis. He had a valve problem. We had to replace his valve. Then they do the transplant. So this is, after that, he started writing a lot of books on marriage and many things. So he's a popular pastor in Nigeria. Now, this again, my own survival figures of African survival figures. These are not actually, if you see, they're not very scientific. Roughly taken from my records, the 1-year survival is 95%. More or less matches with my Indian figures. 20 years is about 50%. This is my Indian figures. The African figures more or less match now. Now I come to the one important thing is the African patients of mine didn't have diabetes, which is surprising. 83% didn't have diabetes, 17% had diabetes. I think that is the only difference I noticed. My own patients, if you see, majority of them had diabetes. And if you look at sex distribution, similar to India, 80% male, 20% female. And then hypertension, all these are some of the figures we had. And why did they lose their graft? Commonly is poor compliance and 66% unknown, similar to Indian scenario. And this is a very important slide. I think last few slides I would close now. The challenge in organ transplant in Africa and India are similar in many ways. Africa is what India was 10, 15 years ago. Now I just put this traffic taken in 2 countries. Tell me which is India. This is Nigeria, Lagos, and this is Calcutta. There's no difference. We are same in many ways. Our culture, our way of doing things. So we can learn from each other in many ways. Our religious beliefs. The one thing which I would want my African colleagues is to know about the law and ethics. If you look at the donation, in India at least, 80% of women donate. 20% of the recipients are women. So if you look at the kidney donors, 80% are women. If you look at the recipients, 80% are men. So this is again, which is going actually improving better. 30 years ago, when a wife got kidney failure, the husband would give her divorce and run away. But now it's changing. The wife gets kidney from the husband. I see husband donating kidney to the wife at least quite often, which was not there 30 years ago. Because the women are educated, they're earning money. I think that makes a difference. The emancipation of women or the female is very important. Now, this is another important thing. Recently we had a woman had to call off her engagement because her fiancé said she can't donate kidney to the mother. So this girl was very smart. She said, I'm going to break the engagement. My marriage is not important. Donated kidney to the mother. So these are things which are occurring in India, and I'm sure it's occurring all over the world, which is a good sign. Now, this is another, I was talking with Joe Hospital. These people came from Ethiopia, and they said no blood transfusion. So do you do transplant? So we had to do it. Our surgeon was very confident, and they had given consent, and they are very clear. Even if there is bleeding, they will not take blood. And fortunately, they did well. And these are some of the challenges we have, whether we have to follow religious belief or not. This is not just in Africa. We have the same problem in India. We have, astrologers deciding on transplant. We had a swap transplant, and we had two different, the recipients from different backgrounds. One was from a village, one was from a metro city, and the two astrologers, the village astrologer and the city astrologer, gave different dates. And we said we can't do the transplant like that. So finally, I had to come down and say, my astrologer is going to give a date. You are not going to go by your astrologer. My astrologer will give you a date, and then you do the transplant. Transplant went off well. Similarly, I have a story from Africa. This young man came to me for transplant. We did transplant. Within a few years, he lost the graft. When I asked him, what happened? Have you stopped the medicine? He said, yes, I stopped medicine. I asked him, why did you stop the medicine? He said, Jesus told me to stop. Then I did the second transplant, went on for a few years. Again, he comes back, loss of graft. Again, I asked him, have you stopped the medicine? He said, yes. Then I asked, why? He said, Jesus told me to stop. Then I told him, I'm doing the third transplant, but this time you will not stop medicine. Jesus has to tell me to stop, then you stop. Now it's about 5 years after the third transplant doing well. So these are things which occur in all countries. So it's very important to know religion, culture plays a lot of role in our transplant procedure. This is again an old story where we had a man with kidney failure. The only donor was his brother, who was 100% match in all ways, but he was deaf and dumb. So how do you get consent? Can we do the transplant? So we had to go to the Indian court. We had a lot of things. He was only available. He was the only sibling. He had no other sibling and a widowed mother. So the judge, I'm sure Lloyd knows this, Justice Michael Saldana, a very brilliant judge. So he gave a judgment. He said that if you don't do transplant, this patient will die. If the recipient dies, the donor also will die. Because the recipient's wife, first thing she will do is throw the donor out, the brother out of the family. So it's in the interest of the donor, go ahead with the transplant. So we did the transplant. The recipient is still going on 25 years now. The donor passed away last year due to some COVID infection. So, but after that, we are not done. So one of the accusation was that if you do such a transplant, it's a slippery slope. A lot of mental retarded donors I would take. No, it is not like that. If you have your own ethics, it won't occur. I have never ever done. This is the only case where we took a kidney from a disabled person who was deaf and dumb. But it hit the headlines. We are in BMJ, we are in Lancet, we are in all newspapers. In fact, in any ethics transplant, you will have an article on this subject. Important subject, 95. We are all accused in Bangalore. Lloyd also will know of stealing kidneys. Bangalore was the hotspot. They said thousands of villages came to Bangalore. They came for blood donation. Their kidneys were stolen, and it's all wrong information. That time, till 95, India had no law regulating organ transplantation. So we could buy, sell a kidney. So we had middlemen who would cheat. And because of this cheating of the middlemen, the police came in and some of the doctors were arrested. It became a big scam all over the world. In fact, the first time BBC put, if you see the BBC news, kidney thieves hit Bangalore. So all of us were accused. In fact, this is 1995. It's my brilliant colleague, Dr. Balal, chairman of Manipal Hospital, and me. We were trying to convince the commissioner of police that there is no stealing of kidney. It is only stealing of money. It took a long time to convince, but one good thing happened. In all crises, good thing occurred. The Human Organ Transplant Act of 1994, The act was in the parliament, but it was not passed. But this scam made the human organ transplant come in. So what did the act say? It said refine death as brain death, permit removal of organs from brain dead cadavers for transplant, prevent sale of organs, close relatives can donate, close, how do you show who is close? Unrelated donor transplant with the permission of the government. So this is the Organ Transplant Act. Now, you must understand, one of the problems of all the scams is because of organ shortage. There is no organ, whether you do cadaver or whatever, number of organs are less. So the cases also go up. So if you look at the medical legal cases, the maximum number of cases are organ transplant in India. Actually, this is one of the cases I can see. Many cases are there on various causes in a realm of organ transplantation. So what happened was in 1995, the organ transplant episode, my own figures, we were doing about 180 transplants. It plummeted and number has still not come up. That one episode put the whole transplant scenario in the background and the whole country. But it did form certain rules, I think, but the rules are also stupid. At that point of time, a grandfather was considered unrelated as per Indian law. See, India, we have a joint family system. The father, grandfather, all of us, and now it's changing. In fact, I was living with my grandfather. My children were living. We are all 4 or 5 generations in the house. But the Indian law, they copied the British law verbatim, which said a grandfather is not related to the grandson. So this grandfather was 80 years old, wanted to donate to the grandson. The government refused to give permission. They said it's unrelated. They will not give permission. Again, we had to go to the court. With a court order, I did the transplant for this man. This old man, at the age of 80, he donated. He died at the age of 95. And this young boy still going strong after 30 years or 25 years of transplantation. Now, organ shortage continues. What do we do? How do we improve organ transplant? The waiting list is long and this is going up. Organ donation, cadaver donation is going up in India, but still not enough. So we started the disease donor transplant in Bangalore in the 1997, 98. You can see me actually as one of the earliest cadaver transplants in Karnataka. This young me taking the kidney from St. John's, Rebecca Thomas. Actually, we didn't have any green corridor. I had to take the kidney in my small car and take it to another hospital for transplant. But look at this now. Now you've got flights, you've got ships taking off. And recently I have said 2020, Italian police used a Lamborghini to transplant a kidney. This is a big news. We had done it in India 25 years ago in a small car, but Lamborghini taking a kidney is social media is going viral. That's the thing. Now, again, how do we increase the organ donor pool? Using HIV positive donors. I'm sure a lot of experience from South Africa. We have a colleague, Rajiv from South Africa. I'm sure he'll be tell us how we could use HIV positive donors. But I must give credit to my good friend Brian Pereira, because he's the one I would say is guru of hepatitis C in dialysis. Before Brian actually told us that if you have, we were used to think that if somebody has got hepatitis C, it is bad, they can't go for transplantation. It was Brian Pereira who showed that if you have hepatitis C, it is better off to have a transplant than be on dialysis. Definitely hepatitis C compared to a non-hepatitis C, the mortality is more. But if you compare to being on dialysis, so somebody with hepatitis C on dialysis definitely does better with a transplantation. Another important thing which has come up after Brian's study is using hepatitis C positive donors because of new treatment which is available. You've got direct acting drugs. So anybody who's hepatitis C donor, you can use it in hepatitis C recipient and then treat the recipient with the drugs and go away. And we can get more donors. These are some of the ways to increase donors. Then the other important thing, this is a very contentious topic, whether we should allow organ sale. Can we buy or sell a kidney? I have my own theory. My own theory is that we not, maybe organ sale is not the right word, but we have got to remove the disincentive. Please understand, when somebody donates a kidney, they are off from work for a month, their medical expenses. All this has to be taken care by somebody. So I proposed, we had a meeting in Manila. Actually, we had a paper. This is the paper, Incentives for Organ Donation, Proposed Standards for International Acceptable System. It was read by, the whole team was read by Arthur Matus, and many of us were there. I was also one of the co-authors. What we said was, remove the disincentive. So a person who donates a kidney is treated like a war hero. He's given a medal. With the medal, you'll get free train ride. He'll get tax redemption. His children will get free education. He'll get fixed, the interest rate in the bank will be more. So remove the disincentive. That is one way of improving organ donation. Same thing can be done for cadaver donor. Somebody's family is a cadaver donor. That family gets a lot of these benefits, which is not sale, but removing the disincentive. That is one way we could go about. And this is a big debate. This was there a big debate in Singapore, which I took for whether actually you should allow in some form, some payment. When this lady, Sally Sete, she has an unrelated transplant, a psychiatrist, US. She said, altruism alone is not enough. We need to give some sort of incentive in some way. How do you increase more transplant? Domino transplant, which is catching up. All of us know about Alvin Roth. A swab transplant. We have all done this. This is all big news, especially if we have a different religious couple doing swab. It becomes big. But I think my other kind of colleague from Gujarat, he has done a lot of swab transplant, which is catching up well. This is one way to increase the number of organ donors. How do we increase? ABO incompatible. This is another way to increase organ donors. Now, the question of printing kidney is still not there. But I personally feel, I think this is the way it's going to be. The organ shortage, in my personal opinion, is the answer is in pig xenotransplantation. Pig kidney xenotransplant by, Bob Montgomery. He himself is a heart transplant recipient who has done this pig transplant. I think the answer to me is xenotransplant or pig transplant in the future. Now, cloned kidneys, I don't know, it's still not caught up. But one other thing, again, I would like to spend a few minutes is the role of social media. Is it good or bad? Some time ago, somebody in the WhatsApp impersonated my name and said I'm a kidney buyer and used my name. But the other side, this is the problem of social media. There are good sides also. That's why I'm on Twitter, I'm on LinkedIn, I'm on Thread, I'm on Instagram. It can promote organ donation. It can talk success of transplant. It does help. I think social media used in the right way is useful. So please be on social media. Very important. Now, look at the cost of treatment. This is American treatment, 1998. It's very expensive. It is so expensive, even a country like India, even a country like US cannot afford ESRD care. So what do? So I quote Dr. Mani and my guru, Dr. B.M. Hegde. They said, swastasya swasta rakshitam. That is, keep the well healthy. Prevention. How do you prevent? If you look at the entire economic facts of any country, whether it's India or any other country, you've got to prevent CKD, whether diabetic. How do you prevent? All of us know this. I'm not going to waste time. Sugar control, blood pressure control, no smoking, no NSAIDs, treating UTI, identifying, using drugs, all that. The last slide is very important. Again, this is by my guru, Dr. Shastri. You said there are 4 Ds actually. The 4th D I would tell you: doctors, drugs, dehydration. We are dangerous. The 4th D he said was, in those days in Bangalore, was dangerous snakes, because snakes would cause kidney failure. Now, this again is my favorite slide, smoking. So smoking actually causes impotence. That's why this is the Marlboro man who is supposed to be a handsome man. After smoking, his cigarette also has become impotent. So that's one way I tell my male patients, if they are smoking, that they would become impotent with smoking and stop smoking. And the last slide, the question is, what is the role of a nephrologist in transplantation? The nephrologist doesn't operate. He collects money maybe. But this is me 30 years ago actually praying. This is my chief surgeon, all of them operating. I think prayer is very important. I was trained in a place called Christian Medical College, Bangalore, and my guru was Professor Meshak Jnanamuttu Kribakaran. His father was a pastor. So he would tell me, and the whole team, whenever we had a sick patient, he said, please pray. Because if you pray, we will get the right diagnosis. God is not going to come in human form and tell you what is the diagnosis. But by prayer, you will get, suddenly some resident will get some diagnosis and we'll get success. So I believe in prayer, and I keep praying every time during transplant, before transplant. My whole team prays. My surgeon, without prayer, he never operates. As long as mother was alive, you take blessings from her. Does prayers and then only goes for transplantation. Now, thanks to these prayers, we have a lot of urine, but the Chinese still beat us. I don't know what prayers they do, but they seem to be making more urine than us. Now, in the modern world, if you look at it, all transplant, if you look at Grey's Anatomy, the picture, the series, it says all transplant surgeons, they are like vultures now. This picture again is by my colleague, Dr. Ajit Tuhilgol. He's a BBC award-winning wildlife photographer. He took this photograph. These vultures have disappeared in India because of diclofenac used in practice. But these vultures, one is asking for the heart, one is for the pancreas, liver. So our surgeons, transplant surgeons, have become like this according to the media. I'm not saying this. Now, I end last with my favorite author, who is a mythologist. He's called Devdutt Patnaik. He says, who sees it all? Varuna has but 1,000 eyes. Varuna is the god of rain in India. Indra is the god of heaven. Indra is 100. You and I, only 2. So I'm giving you my picture with 2 eyes, my story in the last 4 decades, what I know. Thank you very much. I'm sorry if I bored you. I'm ready to take, if there is time, any questions. Thank you.
Thank you, Dr. Sundar, for a very enlightening discussion, and we enjoyed to listen to your experiences over 30,000 transplants. I just want to open the floor to the panelists and hosts for any questions that they may have. Please feel free to unmute yourself and ask any questions.
I think, Lloyd, there is a question on branded drugs and generic drugs. Can I take that question?
Yes.
Please.
This is a very important, Hamza. I think this is a hot topic right now in India, because what happened was a week ago, the National Medical Council, this is the equivalent of the GMC of UK, which regulates all doctors. They put a rule that all doctors should use only generic drugs. They can't use branded drugs. In India, we have got branded generics. India is the capital of all drugs which are generic drugs, but there's something called branded generics versus non-branded generics. So the medical council said all doctors should write only the generic name. So if you want to use tacrolimus, I can use any, the original innovator brand is Prograf. But there are at least 20, 30 brands in India. Each of us will use different brands, whatever. What we said was, in my experience, Indian generics are excellent. But I have done a study with Dr. Vijay K. and we have followed up. It is not correct to change one brand to another. If you stick to one brand of tacrolimus, please stick to that. They have done a study. If you change from X brand to Y brand, it is like doing a new transplantation. The patient has to go for regular TAC levels, regular kidney function monitoring, at least for a few months. So our rule, our advice to all patients is, do not switch from one brand to another. Now the question comes, during COVID, what happened was, some brands were not available. So that time, don't say, I don't have any, that brand is not available, and stop any medicine. Take whatever brand, but then monitor, do a TAC level. We are fortunate we can do a tacrolimus level. We can do a kidney function test. But the same thing is not available for mycophenolate. But in my view, mycophenolate is an adjuvant drug. I have no problem in switching brands in mycophenolate. But again, in this, there is a problem. My colleague from Bangalore, Lloyd would know, Dr. George T. John from CMC Bangalore did a study, a wonderful study of using different branded mycophenolate sodium, not this mycophenolate mofetil. So he compared myfortic, the original mycophenolate sodium, with the branded mycophenolate sodium. He found a lot of difference in the levels. So George T. John even now tells me, if you are going to use mycophenolate sodium, use only myfortic or the original brand. Don't use any other brand. He says, if you want to use MMF, mycophenolate mofetil, use any brand. There's no problem. But sodium is difficult to make, and each generic brand, there's a lot of difference. So his advice, I follow. Tacrolimus, I use generic, branded generics. As far as possible, I don't shift brands. I see some prescription. Morning, they'll be in X brand, evening, another brand. Don't do that just to please the pharma. It is wrong. Stick to same brand. If you are changing the brand, please consider as a new transplant and do the levels every week. Do the kidney function at least for a few weeks. Then only you will be comfortable. That's my advice for branded generics. I have no problem with prednisolone. There are many brands of prednisolone. In fact, prednisolone, sadly, the original fellows are not making, but there's not much profit. That's what my colleague Dr. Hariharan told me. Hariharan from Starzil Institute retired. He told me, none of the big pharma companies will talk to you of stopping cyclosporin or tacrolimus, because they'll only say stop steroid, because that is the cheapest drug. A country like India, which is poor, or Africa, we can't stop steroids. That is the cheapest drug to keep, man, in transplant. 5 milligram tablet, small dose, nothing will happen. So according to Hariharan, use generic branded tacrolimus, same brand, mycophenolate mofetil, no problem, prednisolone. This is a triple drug regime he advises. Yes, sir.
Very interesting session, sir.
Lloyd, you're muted.
Very interesting session, sir. Thank you for sharing your journey right from the days when only azathioprine and prednisolone were available to an era where we have so many cross-match techniques and so many drugs. I mean, not so many, but still, I mean, you have really had too many success stories. Always a pleasure to listen to them.
Thank you.
Absolutely. Anybody, any questions?
This is one Agrabi asking maximum number of transplant in one patient. In my own team, maximum number is 4. 3 is quite, I have seen quite a few, 3. 4 is seen, but I think, I remember Dr. Shastri telling me that one patient of his had 7 transplants. I forget the name. And he told me a very interesting story. The 7th transplant, He had 7 transplants, and he died. You know how? He was traveling in a car somewhere, and he got down because the car had a puncture. He was trying to change the stepney, and he got hit by a lorry or something and died. 7 transplants dying because of a car accident. See the irony of fate. And patients come and ask us, can you guarantee transplant? Nobody can guarantee. Even without transplant, we can't guarantee anything in life.
I think
Anybody, any
there's
question?
someone who's raised
Doctor,
their hand.
I think it has been actually a privilege to listen to your talk that involves several decades of experience in transplantation, and especially involving so many patients. And I think and it has been a very interesting talk. And thank you very much for this talk that you've shared with us. Now, but something caught my curiosity about this 8-year-old grandfather who donated to his grandson. It's great the grandson is still alive. I'm not going to ask questions about that. But there has always been caution in selecting donors, especially being among them, the donors who are less than, who are more than 60 years. And they even go ahead to say that if anything between 60 and 70 is extended donor, that can be given to somebody, but with the high risk of rejection, which are also given to selected patients, over the age of 60, those who are likely to die again in a few years. Now, can you tell, with this, in my view, this 8-year-old grandfather who donates a kidney to a grandson, and this still alive, actually, it challenges that theory. Can you comment on that?
Lloyd, can you explain? I'm not able to hear clearly. What is the summary of the question?
Okay.
Elderly donor?
Dr.
I'm Dr. Mahendo from Rwanda.
Yeah, senior consultant nephrologist in Rwanda.
Tell me, sir, you want to know about the elderly donors, our experience?
The 8-year-old donor who gives a kidney and the recipient lives for a long time, challenges the traditional attitude
by and large,
that the mass gets less and less, and it becomes almost useless when somebody is above the age of 60.
The GFR of the kidney would have been low at transplant.
See, that's an interesting question. See, what happens is as you grow older, GFR comes down. But that is why our cutoff, for old people is different. See, in fact, this is better for us to take an older person than an younger person for donation, according to me. See, if you take an 80-year-old person, his lifespan is another 10, 15 years. But if you take somebody who's 30, that's why I'm very reluctant for a son to donate to the grandfather or father. I'm happier that the father or grandfather donating to the grandson rather the son donating, because he's got a longer lifespan. And that is why the earlier our cutoff was 65, upper limit for donor. Now we have even 80, 85. We have a lot of my colleagues doing, my colleague on Sanjay from Bangalore, one of my former students, he has got many donors who are above 80 and he's taking them. So of late, we even started taking diabetics because we have shortage of donors. So we take somebody who's 60. Earlier, we were not taking diabetics. I do take above 60, somebody is diabetic, not an insulin, no end organ damage, good control, we do take. So certain things we have to do, and only time will tell us what we are doing is right. Because we were all along talking that kidney donation is safe, but now we know that is not all that safe, because quite a few donors are getting into CKD. So what do we do? So it's unless we do, we won't know. But your question is warranted. But my suggestion to my African colleagues is, I was in Zambia. I think it's time you started transplant. You get the organ transplant act quickly by the government. Otherwise, you're going to land up in problem. The problem I had was because I had no law. All these illegal things are occurring. I had no protection as a doctor. If you have a law, you're protected by law. Any transplant is cleared by the government, then you're protected. Tomorrow, the media, the police cannot harass you. So my suggestion to my African colleagues, and Lloyd is powerful in Africa, see the law is passed on organ transplant with certain parameters. It can be a little more liberal. In some, like India, only close relatives, only younger, no uncles allowed. Your father's brother is not a relative as per Indian law. Your mother-in-law is not related in Indian law. Your mother's brother is not related. In India, these are all close. So we can change that related transplant a little bit and get the law for transplant, and all unrelated to be cleared by government, so the doctors are free, So you got to get the law going. Otherwise, it will become like India, where we keep getting scams. You'll have problems because there is disparity in wealth. So you're going to get scams. You've got a desperately poor person, no money for food, committing suicide, and another rich person who's dying without a donor. It's a recipe for disaster, for exploitation. So if you have a law, at least some amount will be protected. So I would request all my African colleagues, get the law in place for cadaver transplant, brain death, and transplants. That's my advice.
Yeah, because I think the issue of the law doesn't arise. In fact, I'm the one who championed the first kidney transplantations in this country, and I actually didn't want to get involved unless there was a law that was protecting me, and I had support from the Ministry of Health, and this was quickly done. My only question, the only issue was the age of this. The age of the donor. The age of 80.
No, your point is correct. This is not common. Elderly donor is not common. It is very selective. Unless the kidney function is good, healthy lifestyle, then only we take. And there is a lot of literature on elderly donors now. It's not that India itself, I think my colleague has produced, I'll send you the paper, where above 65 donors, what is the problem with the recipient? See, we have to look at what is ideal. Ideal is an identical twin, but you don't have ideal situation in India. Because only now dialysis centers increased. 20, 30 years ago, people couldn't even go for dialysis. So we had to look at the option. What would happen? If you don't transplant, they would die. So we had to balance out between this and that. Your point is valid. I think we need our own studies on elderly donors, but there are limited studies in India which have said that elderly donors, by proper selection in a good center, we can take.
Dr. Bhima.
Yeah, thank you, Alan. Dr. Sundar, thank you very much for the very enlightening presentation. I'm really impressed by the work that you're doing there. Obviously, from your presentation, the majority of your donors are live-related donors. Am I correct?
See, before 95, it was live unrelated, actually, because the law allowed sale of organs. So before 95, 80% was unrelated, 20% was related. Now, unrelated will be, even spouse is unrelated as per Indian law. Mother-in-law.
The majority are live donors, okay?
All are live donors. My cadaver donor is not even 5%.
Okay, so the movies, especially in the pediatric population, we're trying to move more towards doing preemptive transplants.
Yes.
You've got a lot of preemptive transplants, or are you still waiting for dialysis and then transplanting them?
I think pediatric preemptive, if they have a live related donor, that will be the best. There's no question at all. It will help you in growth. It will help you in the quality of life, getting back to school. But the problem is getting the live related donor. That is the problem we have. But if we have, not only in pediatric, even in adults, a preemptive transplant with a live related donor is the best. They've got the best survival rates. That will be the ideal. But most of the times, life is not ideal. No, that's the problem we have. Yes, sir.
Dr. Gonda.
Dr. Anthony Gonda. Yes, sir.
Yes, Dr. Lloyd, thank you very much for this chance. Actually, I've listened to Dr. Sundar. He has given a very nice talk, actually. It's $1 million talk, and I think he will deserve maybe 2 or 3 chances, because he has a lot of issues to address. But with the limitation of time, he has been going a little bit faster. I think if he had enough time, he would deliver material which are not written in any book. I would like to ask one question.
Yes, sir.
We have sometimes we get patients, poor patients, who would like to do transplant, and sometimes they could be able to get donors from their relatives. But the problem comes, like, you also plan what will be life after transplantation. And this is the issue of immunosuppressants. Now we know the immunosuppressant, the current one, are a little bit very expensive, particularly for poor people, and in particular, the patients of our part of the globe.
Correct.
So Dr. Sundar has a very good experience, I think, all across the globe. And I would like to ask, from his BC and AC experience, what is the cheapest and effective combination of immunosuppressant you would like to offer to a poor patient, but still you are sure the graft will be safe, but still they can afford with their minimum amount of money they have? Thank you.
I think it's a very important question, not only for Africa, even in India. India also, we have many centers. There was a center in India. We had a Baba called Sai Baba. He had his own hospital and he was doing free transplants. The surgeons his own devotees would fly down from California or some US or UK and do the transplant surgery free. But after transplant, the person didn't have money to eat. So he cannot take the medicines and they were losing the kidney. So this is a problem which we're facing. So what I suggest to any poor person is first bring me proof that you will have enough money or enough resource for at least the next 5 years to take the drugs. A lot of people are willing to give capital expense. They will do free transplant. They're ready to give capital $5,000, $10,000 for a transplant. But recurring expense in India for a transplant, the first year, first 2 years is about $500 a month. Generic drugs using tacrolimus, azathioprine, prednisolone, roughly about $500 a month for the first 2 years. Then roughly about $100 a month lifelong. This is the amount we have to use in India. If somebody cannot afford that, it is very difficult to transplant. So you'll have to work on charitable organizations and other things to support them after transplant. For the transplant, they'll get money. The other thing, one way, my own feeling is to use tacrolimus, azathioprine, prednisolone. The mycophenolate portion is very expensive and you don't need it. If it's a close related transplant, I have many patients only on TAC, AZA, and prednisolone. So that is one way to reduce the cost. But your point is very valid. This is a very difficult question to answer because this is a social problem more than medical. But you have to be guaranteed that they get drugs. Otherwise, you're going to have a problem. 10% to 20% of our patients lose grafts because they don't have money to buy the medicines in India, which is a fact all over the world. I think even in countries like US, they don't have insurance. They have this problem.
Good evening.
Yes, sir.
Good evening.
It's been a lovely presentation by Dr. Sundar.
Thank you, sir. Thank you.
I'm happy that I had an opportunity to meet you when you came to Zambia last year to conduct the kidney transplants. Yes. I've noticed from let me say that I'm also a kidney transplant recipient.
Correct.
But my question basically is, I've noticed that most of the kidney transplants patients in my country are developing diabetes. I'm aware that prednisolone and tacrolimus give those effects.
Correct.
But my question is, does the brand contribute to a patient getting diabetes or to poor quality of a patient?
I think it's multifactorial. One is definitely the drugs like tacrolimus and steroid contribute. This is called NODAT, new onset diabetes. But after a couple of years, once the TAC level comes down and the steroid comes to 5 milligrams or something like that, that effect goes off. That is the lifestyle. Because what happens, your appetite improves, then you start eating a lot, especially you eat sugary stuff, sweets and those sort of things, and you don't exercise, the diabetes worsens. But it is easy to control diabetes by these methods. One is good lifestyle change, diet control, exercise. It's possible to control. Only other option, somebody has got due to diabetes, kidney failure, is doing a kidney pancreas transplant. I have no experience of that. And that's, in fact, some people are asking after transplant diabetes, they want to only pancreas transplant. I don't think anybody does like that. I have not heard. Have you heard of that, Lloyd? After transplant? Only for diabetes doing pancreas transplant, I don't know.
That's type 1, yes, but not otherwise.
One other question I think somebody asked about legal aspect. I think it's a very important thing. I didn't spend much time. In my opinion, in a transplant, more than medical, it is legal, which is dangerous. I have had all types of legal problems, from impending arrest to, you name it, to the court, to the police, everything is there. Fortunately, I work with a big hospital with a big legal team. So most hospitals having a transplant surgery will have a big legal team which supports you. About 10 years ago, I was sued not by a transplant patient, by a dialysis patient. In fact, I asked Brian Pereira to be expert witness. This person claimed that he got hepatitis C because of my center. He came from another center, and when he was on dialysis for 2 days, and when we got the hepatitis C screening, it was positive. And he claimed that somebody in my team injected hepatitis C, and he sued me for $15 million. That's what he claimed. But he's still going on. 15 years now, it's still the court case is going on. I'm sure now hepatitis C is so treatable. By now, if you are not treated, he's a fool, and treatment is cheap. But like this, there are cases. Patients have died after transplant with some sepsis. They'll say you are given sepsis. And then invariably, it is the problem of the donor. Somebody who's donated kidney, we think is a related transplant, but actually it is a paid organ donor. But those things have been more or less solved in India in the last 20-25 years because of the committee which clears transplants. All transplants have to be cleared by a committee. If it is related, it's a committee in the hospital. If it is unrelated, a committee from the government. So we are safe that way. We are protected. In fact, that way we have not had any problem. That's why I keep telling, please get the law in some form. And even if you don't have the law, let the donor recipient be cleared by your hospital management. Let them be involved. Let there be a social worker, a police officer, a journalist, something like that, who will interview both the donor recipient and get it cleared in a paper properly. Then you are safe. The transplant team is then not directly involved. You won't be accused. I think that's the first step we have to do.
Thank you, Dr. Sundar, I think, for the very enlightening talk. Thank you for creating time. We have learned quite a lot, and I think there are no other questions. And so on behalf of the African Healthcare Network and the panelists, I want to say thank you and wish you a good evening, and hope to have you soon to again learn more on your vast experience and also tap into that. Thank you.
Thank you.
Thank you. Thank you very much, Dr. Sundar. A wonderful session. So much of experience, and it was great sharing with the entire community here. Thank you very much for this wonderful evening and all the time that you spent with us. I hope to see you this side. I hope to see you this side sometime.
Sure.
Thank you.
Thank you.
Thank you, Dr. Tapoti, for being around. Thank you very much. Nice meeting up as well. Thank you so much. Thank you. It must be very late there too.
It's 11 o'clock, not very late. Thanks, Lloyd. Take care. Bye.
Thank you. Thank you, Dr. Thank you.
Thank you.